them told just to get off so they can see on the screen. This is Dr. Sarah Blenner. Sarah is an amazing faculty in the School of Public Health. And she's been with us for several years now. And we're so delighted to have you there as our expert on policy issues. So in preparation of that trip to Washington, D.C., the advocacy, we just got a little bit of a preview from the Academy's perspective, and the residents will tell you all about it. But I want to thank you first and foremost for being with us today. I want to welcome you again for this year. So you meet the residents. Maybe I'll let them introduce themselves so you know who they are, Sarah, before you introduce yourselves, okay? Matt, you want to start?
Yeah, of course. Hi. I'm Matt. I'm one of the first year PEDS residents. I'm from Southern California. More specifically, I'm from the San Fernando Valley. I went to UCLA for undergrad, went to UCLA again for dental school, and now I'm back here for residency. So nice to meet you.
Nice to meet you. And then Dr. Ramos as well, just really quickly, we also have 2 public health students. So maybe in the introductions, they can also introduce themselves. Go ahead, Mark.
Hi, Dr. Sarah, I'm good. I'm Dr. Mark, nice to meet you. I am from Atlanta, Georgia. I went to University of Georgia for undergrad, and then I went to University of Alabama for dental school, and I'm here for residency. It's nice to meet you.
Nice to meet you as well. I have a particular place in my heart for Atlanta. I went to Emory, so I spent
awesome.
Yeah.
And call Ida next. You have the popcorn, Mark. Ida, say hello, introduce yourself.
Sorry, hi. My internet in my apartment is really bad, but I'm Ida. I went to Harvard for dental school. So I moved from Boston to LA, and I'm excited to hear about our topic today.
And you're going to ask Marisa to go next.
Hey, Sarah, I'm Marissa. I was born in Atlanta, raised in Marietta. Emory was actually one of my choices for undergrad as well, but I ultimately decided to go to Limestone College, where I played basketball in college. And then I went to the University of North Carolina for dental school, and now I'm here as a resident, and I'm super excited about today's presentation. Thank you.
Next is Wes.
So I'm Wes Johnson. I went to the University of Minnesota for dental school, and then I practiced for several years with Indian Health Services, and came back to UCLA for residency.
Great, Vishnu.
Hi, my name is Vishnu. I went to the University of Utah for undergrad, then went to NYU for dental school, practiced for a year in Massachusetts, and now I'm here at UCLA in PEDS. And yeah, excited to hear what you have to say. And I popcorn to Tarek.
Hi, my name is Tarek. As all my co-residents have said, they're first-year residents, and so am I. Was born and raised in the far, far away place called Santa Monica, which is just like 7 miles west from UCLA. I went there for undergrad, dental school, and now obviously here for residency. And as everyone has also said, I'm very excited for this lecture.
I'm sorry, if you want to introduce your students, Claudia. Is there like a popcorn, Claudia?
Hi, everyone. My name is Claudia Martin. I am a 1-year postdoctoral MPH student. I am a family medicine doctor, and I'm currently completing my program for an MPH in the Department of Health Policy and Management. Excited to be here.
That's wonderful, Claudia. That's what Vishnu and Marisa, they forgot to mention, that they are also the MPH folks. Maybe you guys can maybe put a little bit thumbs up or something so they know who you are, because you might meet them in their classes, Claudia. They might be your classmates.
Sure, yeah.
Absolutely. I was going to say, I think you mentioned that you're a postdoc student. That's amazing. We're still master's students, so I'm not quite sure if we'll have overlap, but if we do see you in our classes, that would be amazing.
Awesome. Thanks, Vishnu.
And Regina.
Vishnu, are you in the HP program?
Yes.
Okay.
Both of us, yeah.
Yeah, Vishnu and Marisa, both of them are in the MPH program right now.
Great.
They are the warriors. They're the heavy lifters. Regina, you go next.
Hi, my name is Regina. I'm currently a 2nd-year MPH student in Community Health Sciences, and I studied my undergrad at UC Davis in psychology.
Thank you. So Sarah, you want to introduce yourself and tell them all the amazing things you do besides being an amazing faculty, an amazing mom, and an amazing teacher, and all the things you juggle.
Thank you, Dr. Ramos. You're too kind. I really, first off, I want to thank you for inviting me and the public health students today. I really enjoy our collaboration with pediatric dentistry. A little bit of background about myself. I have my JD or my Juris Doctor and also my MPH. My focus was in health policy and administration. Before coming to UCLA, I was practicing law in Chicago, where I was the director for the Center for Diabetes Research and Policy. So there we provided some pro bono legal representation on behalf of individuals with diabetes, mostly children who were experiencing discrimination at school. But we also did a lot of interprofessional work. So I collaborated with diabetes endocrinology departments and the psychology department, biomedical engineering, to do some research and also advocacy work as well. Here at UCLA, I'm the Director of Field Studies and Applied Professional Training. So I wear a number of different hats. One of them is I oversee our field studies experience in the Department of Community Health Sciences, which is our required applied practice experience. And then I also kind of am involved with some training programs. I lead the interprofessional education efforts at the school where we have a joint class actually with dentistry and medicine called PH 401. And I do some other things as well, but meeting with you yearly with the pediatric residents is one of the highlights of my job for sure. So it's kind of a special situation we have here because we have a couple of public health students as well as some of the residents. So I thought kind of as a little icebreaker, I want you to take a moment to think about some of the pressing issues that face your profession. So what are some of those pressing issues in pediatric dentistry or in public health that you're particularly interested in? And why don't we go around and share, because I think it'll be interesting to hear the perspectives from the different professions. Anybody want to get us started?
I think one of the things that is, there's several things. I think the first thing that kind of comes off the top of my head, just because we've been monitoring a lot for general anesthesia cases, is we get a lot of patients who come from very far away to receive full mouth dental rehabilitation under general anesthesia, because I guess dental anesthesiologists aren't getting compensated enough to perform those procedures in the private practice setting. So we'll have patients coming from Bakersfield, Ventura, some from even far away as Fresno or even further, just because there's no practices in the area that can take their insurance. So you have patients who travel from very far away and they end up going, months upon months without care. And this is something I think that is pretty prevalent throughout the state, because if you go to different residency programs, like at USC, and USC has multiple hospitals that they cover, CHLA, Chalk in Orange County, they all will have anywhere ranging from a 15-month to a 2-year waiting list, which you can imagine is a really long time, especially for these kids who might have teeth that are starting to abscess or they start getting facial swelling. It's almost like you're doing bandage treatment while you wait for them to get the treatment in the first place. And then something tied on to that is that for those who are medically complex, they, again, are getting filtered specifically to the residency programs. And I guess either because a lot of bigger hospitals are now eating up, quote unquote, eating up smaller hospitals, you kind of remove some of those routine care that patient populations in that area would get. And then it just kind of causes a big clog in trying to get people in. And again, it's just the same problem. They're sitting there with several months to a year or longer waiting to receive treatment. So I think that's a kind of a pretty big issue that hopefully can somehow at some point get addressed, because no one should be in pain for that long.
To tease out this in several pieces, like the lack of access to dental care when it's needed for the children that they needed by the specialists they need to see at any given time. So it's an issue of matching the degree of the level of the severity of the disease and with a specialist that they need to see. And we're like tertiary, place here. So we are the last place where these children are referred to after they fail many different appointments and ways. So, but the whole idea of this mess of the insurance, like all the children, 92% of all children should be covered, and they're all covered by public or private funding. But the fact that only 40% or less than 40%, 38% of them are utilizing this coverage appropriately, that's a big prize. So that's one of the issues to address if you tease them out, right? The lack of knowledge or understanding about the system, how this coverage takes place. The second issue, it's about that people, unfortunately, they wait until it hurts, until there's an abscess, until there's an infection or oozing, pus or, horrible things to seek dental care. This whole notion of going to the dental team for just maintenance and prevention is still not being adapted appropriately. And lastly is, the lack of matching of insurance programs, that the children are just, and the families are misled by taking these insurance plans that might be HMOs or PPOs that might be 3-4 hours away from where they live. Is not really done by geographic location. So by the time the parent realizes I need to see a dentist and they have to take 3 buses and 4 hours away, is they're never gonna make it to those services, right? And by the time they get there, like, oh, by the way, the severity of the symptoms child is so badly that you need to see a specialist. So they go back into this running race about getting nowhere. So it's a lot of parts to that whole. It's not that simple, right? So it's a whole, many different parts to get to what Tarek is mentioning. And I'm not sure if you can address those issues. They're very heavy duty, but that's really one of the realities of, of access to care and the problems that we encounter as our profession.
Absolutely. So I definitely can't just address them all now, but I think that it's really helpful to think about how we can collaborate to address them in the future. And the first thing is really thinking about how we kind of frame the issues and how we communicate to each other and where we can find those opportunity spaces to collaborate. So do any of the other residents have any additional comments about like some of those pressing issues affecting pediatric oral health?
Sure. I'd like to add in about patient and parent education, as well as like prevention, because a lot of parents, they are they don't understand that they should be brushing their child's teeth for them, and they don't understand like that once the teeth start touching, they should start flossing, and just a lot of like small things to make sure they intake the fluoride and not just rinse it out with water. Just a lot of different educational things that we could disseminate that information without them coming into the office. So that could help with those barriers of access to care. But then obviously, like Dr. Ramos and Tarek mentioned as well, making sure that once they get in the office, that they have multiple offices that they can reach to be able to actually get that hands-on experience. Because I think, Sarah, you could probably relate to this a little bit. My family's from South Georgia, so Jacksonville and Soperton, Georgia, below Macon, and they literally drive like 150 miles just to go to their dentist. So, yeah.
Other thoughts about pediatric oral health?
I think kind of to build on Marissa, the kind of we do a fairly good job of integrating with our medical partners, but I think having it even further, because a lot of these children, they may not hear those stuff from us because they haven't came and seen the pediatric dentist, but they've seen the pediatrician who can relay a lot of that information. So just another avenue to get that information out and finding ways for us to be even better integrated into that system.
That's awesome. One of the examples I like to give when I'm talking about advocacy in this context is really that collaboration with pediatricians and pediatric dentists as well, thinking about how you can leverage that and make sure that there's that health education piece, like Marissa mentioned, as well as kind of like the screenings and things like that to direct them to care.
Sarah, one of the biggest dilemmas we have in this specific issue is the lack of parity. Just to give you an example, for us, we learned so much about telehealth and teledentistry, right? It's a way to go into the future, how we can really achieve a lot of these visits can be minimized by bringing pediatric dentistry to your household, to your home, where you are, at and to reach you there. And it's very interesting the fact that pediatricians can do their wellness baby visit. You know, they see the pediatricians maybe an average of 10 times in the first year of life of their babies. And some of these visits, the pediatricians were able to achieve parity, meaning that they will get reimbursed exactly the same amount if you bring their child to their pediatrician's office here at UCLA, or if the pediatrician goes into a telehealth visit and do the wellness visit through your Zoom or through your screen, right? But for us, you know, we were able to achieve like maybe $15 reimbursement for telehealth visits. And now they're even questioning if that's too much to pay for dentists to do telehealth. So there's no incentives whatsoever, right, for the dental providers to really jump into this amazing opportunity, where I envision a world of pediatric dentistry in the future that half of your visits are going to be clinical and the other half will be in a telehealth kind of video, bringing this whole disease management and prevention to people's households. We deal with a disease that is a behavioral disease. So we need to nudge parents to act upon their children, you know, on good diet, good nutrition, reduction of sugary foods and drinks, but most importantly, that challenging of brushing their child's teeth every night with fluoridated toothpaste. So how could we do this work by minimizing the incredible effort for a mom with 3 kids to come to your office just for, you know, a pep talk and, you know, some sort of education? If you can maybe go to their households in their homes, you know, without having to commute, without the stressors of getting to see you. So these are just another example of how difficult it is for us to make the case about how these efforts are so much needed and they need to be incentivized appropriately.
So let's transition to public health. So public health, just for the pediatric dentistry residents, it's a really broad field. We do everything from like environmental exposures to the spread of disease with the epidemiology and biostatistics. We have health policy and management, which really looks mostly at like healthcare related issues. And then we also have community health sciences, which is really looking at like designing and implementation and evaluation of interventions and the health education piece and things like that. So it's a really, really diverse field. And so just keep that in mind as Claudia and Regina share with them some of the pressing public health issues that they see, at least related to the areas of their particular interest. So Claudia and Regina, I don't know who wants to go first.
If it's okay with you, Regina, I can go first.
Yeah, sure, that's fine.
Okay. So just listening to all of you speak made me think about one of the topics that we have been covering in our class. Actually, Regina and I are in the same class, which is COVID-19 vaccination and the effect of misinformation or disinformation, and how community-based knowledge is so important to the delivery of information regarding an intervention, how important it is to be utilizing the language of the community in order to incorporate their concerns into that message. As well, because looking at multiple perspectives in terms of COVID-19 vaccine specifically, we've seen that there has been, as we all know, a lot of hesitation to partake on that intervention. And most of it has to do with the type of messaging and going back to what you were all mentioning. In some sense, what I'm hearing is the parents' participation and also recognizing the challenges that the parent has in order to advocate for their child's health. I think that's excellent that that's already brought to the table because unfortunately in some organizations, when it comes to having a policy, that perspective is missing, and that perspective is what really could make or fail an intervention.
Thank you. And Regina.
Yeah, I apologize in advance for kind of how different my answer is going to be compared to everyone else's, but for me, my focus has always been about mental health. I basically grew up in a physically abusive and verbally abusive environment, and so kind of for some selfish reasons, I really wanted to focus on trauma. But last year, my sister committed suicide, and so now I've kind of shifted towards suicide prevention, especially among LGBTQ plus individuals like my sister. I do feel that there's a lot of mental health stigma, especially for certain cultures like Asian cultures. And I do have like concerns about like suicidal ideation in terms of shared decision making among family members. Sometimes the patient doesn't know or have the capacity to make the right decision for themselves, whether it's taking their medication or being able to express to somebody close to them whether they're expressing suicidal ideation. So for me, I feel like that's a really pressing issue, and that's something that I really hope to focus on in my future career.
Thank you, Regina, for sharing that and for being so honest in kind of your motivations and passions for public health. Trauma and mental health is a huge issue that we see, and I'm glad that you're passionate about working towards making change there.
And if I can just start, thank you for sharing also. We are very interested in ACEs. Adverse childhood experiences are very, very well known in the medical field in pediatrics, but very unknown, and it's very unknown territory in the oral health world. So several of our residents are very interested to tease out the ACEs or to look at the validation tools that exist out there to predict this and to assess this appropriately and do appropriate referrals. So we're with you. We don't see our world, especially through COVID and after COVID, without mental and dental really joined together, because usually they're the two specialties in the medical field that they get to be the stepchildren of the system. So we need to really address those very much so. So thank you for bringing that up.
Great. So, oh, sorry, Regina, go ahead.
Oh, just wanted to say thank you. Yeah.
Great. So thank you for sharing. I think it's really helpful to kind of have some framework for the different perspectives that we all have coming into this. And especially as we're thinking about policy and advocacy, it's really important to be able to share what we're seeing on the ground so that we can collectively work together to create change. So this workshop is it's a two-part series. So we're going to have today, and then I think next week we're also meeting. And so the way I've divided it up is part one is really focusing on policy and the policy making process. It's going to be a lot of information this first section, this first part. There will be a little bit of room for discussion, but it's really going to set us up to have a more interactive session next week where we'll engage in some activities and things like that. Does that sound like a good plan? Yeah, any questions before I get started? Okay, so we got a little bit of a late start, so hopefully I'll make it all the way through the policy section. If not, I'll just adjust for next week and I'll pick up where we left off, and then we'll engage in the conversations around advocacy. All right, so I'm going to share my screen here. I have two computers, so I can still see you when I talk, so just give me 1 minute. Okay, so can everyone see my slides okay?
Yes.
Awesome. Let me just make your faces a little bit bigger so I can see you. Okay, great. And then Victor or Dr. Ramos, I'm going to have my chat up, but just in case I miss anything, if you don't mind, just like.
We'll check. No, we'll
no,
and they can raise their hands if they want.
Perfect. Awesome. Okay, so let's start with thinking about what a policy is. So when you think of a policy, what do you think of? Or how should we define it?
I guess something that would impact a significant amount of the population and will serve to assist them in some way.
Great. What else do you think of?
A specific statement or position aimed at addressing a specific topic or issue.
Great. Anything else? Awesome. So a policy is really a general term used to describe a formal decision or a plan of action adopted by an actor, really to achieve a particular goal. So you might think of a law, for example, or what a government actor might do, but it also can be in a private setting as well. So what do you think a health policy is?
Is it just like any type of like laws, regulations, or like course of actions that are implemented to basically promote wellness and like ensure specific health goals for like the entire community or population?
Yeah, absolutely. So it's kind of that same concept of a policy, except for it's going to have some sort of an impact on health. Absolutely. And who's heard of the term health in all policies? Anybody? Anyone want to take a guess for what that might mean?
Health in all.
Yeah, health in all policies.
So policies, so health policies that are geared toward a like community-wide reach so that the health is with everyone. Like it isn't just as it often now the benefits of health policies have certain groups that benefit more than other groups. And so having a more equitable distribution.
Sure, so I hear some themes about equity in there. What else do you think of, or what else do you think? So health in all policies really takes a collaborative approach. And the idea is that pretty much every policy is going to have some sort of an impact on health. So when we're creating these policies, we should really be thinking about those potential health outcomes and really integrating health into our considerations as we're developing those. So the idea is to think about health and policy making across all sectors, including education, for example, and transportation, and not just something that you might traditionally think of as health, such as like healthcare. And the idea is that that ultimately will have an equitable impact and really promote health equity by improving health of all communities and people. So here I have a logic model for public health law research. Has anybody heard of a logic model before? Thumbs up. I'm guessing Regina probably has, and some of our CHS folks as well. So the idea of a logic model is really, it's kind of a way of visualizing how a program or a policy or an intervention is ultimately going to achieve the objectives or the outcomes that you'd like to achieve. And it really helps us see, challenge our assumptions and see all the different inputs that kind of go into it, and then logically thinking through how that will ultimately kind of create the outcomes. So this model here is for public health law, although really you can think about it for any type of policy as well. And the idea is you have the lawmaking, and then that ultimately, like the legislative process, for example, that ultimately creates laws, which could be interventional, infrastructural, or incidental. And then there's legal practices. So how are those laws ultimately implemented? And they can have an effect either on the environment or on behavior, or on both the environment and behavior. And that ultimately will lead to, hopefully, an improvement in population health and individual health. So as we think about that, let's think about an example. There's something called Healthy People 2030. Thumbs up if you've ever heard of it. All right, so I see some thumbs up. It's basically, for those who don't have their thumbs up, it's the national health objectives. And there's actually some related to oral health in there. So Healthy People 2030 has one objective, that is to increase the proportion of persons served by community systems with optimally fluoridated water systems. So the baseline was 72.8%, and the target by 2030 would be 77.1%. So can anyone tell me, I'm sure you know, why water fluoridation is important?
Can help reduce one's susceptibility to getting cavities, which is a pretty big public health measure. I think one of the most successful ones.
Absolutely. You framed that really well. So let's kind of look at the idea of water fluoridation as we kind of think about this model. So first you'd have the policymaking process, and then a policy or law would be put into place that would require water fluoridation. So then the legal practice would be the water fluoridation would actually happen in a specific community, and that would result in a change in the environment because fluoride is being added to the water. You don't have to change your individual behavior necessarily to be exposed to that fluoride, and that ultimately would then have an impact on population health by reducing cavities or preventing cavities and increasing the positive health outcomes by having good oral health. It might be that you need a separate intervention to get people to start drinking the water, the tap water, if they're primarily drinking bottled water. So then you might need a separate intervention for the behavior, but that law in particular would be focusing on the environment. Any questions? All right, so let's jump ahead to thinking about where health policy changes can be made. Does anyone have any ideas? What are the settings where you can make health policy changes?
So like a governmental agency.
Great. Other ideas?
Maybe within a clinic or hospital.
Absolutely. So with healthcare institutions. Other ideas?
Private insurance companies.
Sure.
Schools,
Schools?
school districts.
Mm-hmm. So I'll kind of create a category for that to broaden it a little bit. So organizations generally. Where else? So you're missing the one that's usually the first thing people ask, comment on, and it's probably related to your last session.
Congress?
Yeah, absolutely. So through legislation, whether it's at the federal level with Congress or at the state or local level. Any other thoughts?
Educational institution?
Yeah, educational institutions, and I'll put that kind of in the other category, or potential with administrative agencies if you're thinking about like the Department of Education. So here I just have a little diagram of different places where health policy changes can be made, and you really hit on a lot of them. A couple that we didn't mention yet are executive orders, as well as the judicial systems, so through the court systems, and then ballot initiatives as well. Does anybody remember the three branches of government?
Executive, legislative, and judicial.
Yeah, absolutely. So some of these like other organizations, healthcare institutions, and businesses are kind of in that private sector, but the legislature would be the legislative branch, government agencies and executive orders would fall under the executive branch, and then the judicial system is obviously the judicial branch. Great. So everything in terms of like making policy change, advocacy is really what ties it all together and how we actually achieve the policy change. And really, there's often a multifaceted approach that's needed in order to affect change and to make an impact on oral health. Okay, so let's talk about the legislature. How much did you talk about the legislature in the last session that you had?
I mean, we didn't talk so much about like the overall structure of the legislature, more just like a discussion of how the AAPD interacts with it more.
Okay, great, thank you. That's really helpful. So most commonly we think of that the policymaking process is taking place in the legislature, and legislation can authorize a specific program. It could identify a preference for a particular policy or service. It could mandate or require something. So I'm thinking about like mandatory seatbelt laws or newborn screenings, or it can provide resources such as financial resources. But the legislation really needs to be consistent with the US Constitution. And then at the state level, it has to be consistent with any kind of state constitution as well. So the legislators can't just create laws on anything that they want to. They have to have the authority to enact laws related to whatever topic it is that they want to create a law about. So for example, Congress's authority includes the ability to regulate commerce and provide for the general welfare. And then the states have the rights and powers not delegated to the United States, which allows them to enforce laws relating to things like protecting welfare, safety, and the health of the public. And that's often referred to as the state police power. And then state constitutions authorize state legislative bodies to create laws related to state power. Does anybody know how federal, state, and local laws interact? It's a little bit tricky. Okay, so generally speaking, federal law preempts state and local laws. So that means that state and local laws can't conflict with the federal law. So an example of this would be the Americans with Disabilities Act. The federal government has said, listen, we don't think you should discriminate against people based on disability. So a state couldn't come along and say, we disagree, in our state, you're allowed to discriminate. And they couldn't do that because the federal law would preempt the state law. The state law could, on the other hand, decide that they want to increase the protections for individuals with disabilities, thereby raising the bar, that minimum bar that the federal government has set, and providing additional protections or opportunities for those individuals. Okay, so the varying ways that the different laws interact really creates what we call this patchwork of laws across the country related to health and oral health and also public health. So usually I play I'm Just a Bill. Does anybody seen that from Schoolhouse Rocks?
Yeah, definitely.
Yeah, it's the classic. I really love that video. I'll send the link, or you can just look it up on YouTube. Just for time purposes, I'm not gonna play it today. But as you can see from probably your memory from that video and also from your conversations earlier today, it's a complicated process to get a law passed, and there's a lot of opportunities where that law can lose support or it can die and not actually progress from a bill to a law. So the framers of the Constitution created what we call a dual system of representation. So that means they created two houses. And as you probably remember from Schoolhouse Rocks or your civics lessons growing up, one of those houses focuses on representation based on population, while the other focuses on equal representation of each state. And so this system, the establishment of this system by the framers of the Constitution, is known as the Great Compromise. And then most states have a bicameral system similar to the federal government where they have two separate houses. So did you talk at all about the legislative and regulatory priorities for AAPD today?
We touched a little bit about it, but I don't think they really have been able to match what they told us to do with the legislative and regular. So if you can maybe explain and go through that, it would be helpful.
Okay, cool. So I left it blank in case anybody wanted to share, but there's a link on the slides and I'll share them with Victor to share with you. And then for the public health folks, I'll be posting it on our CCLE site. But basically different organizations like AAPD, which is the American Academy of Pediatric Dentistry, I believe. Yeah, I'm seeing some head nods. Okay, they and other organizations like the American Public Health Association, they usually have an advocacy branch and they develop priorities that they really want to advocate for. And so in that document that I have posted there, there's some they kind of outline what those priorities are and who should be involved in that process. And I just pulled out a few examples here just to give you an idea of the breadth of it. So the first is related to healthcare reform. So in any comprehensive federal healthcare reform legislation, they want to seek improvements to the Affordable Care Act that will, among other things, make pediatric oral health coverage mandatory. Then they have other areas related to the workforce, for example. So they want to support the of HR 1285 and S449 bills that would exempt dental faculty loan repayment programs from taxation to individual faculty recipients, and then include in any comprehensive tax legislation under consideration by Congress. And in their priorities, they've marked that as like I think their #1 priority, if I'm not mistaken. And then they have other priorities that are really related to collaboration. So for example, they want to work with the American Dental Association and other dental and medical organizations to support a simplified process across appropriate governmental agencies to designate individuals with intellectual disabilities as a medically underserved population. So those are just some examples, but they're all pretty diverse. And what's interesting about the example I gave for collaboration is one of the things they really want to do as their priority is to see if there is an interest among other communities to kind of like push that priority forward. So throughout the presentation, I have resource slides. I'm not going to go into detail about them. I just want to pause and note about it, make a note about it. So you'll have these slides. You can see the links to how to follow the progress of the bill and where to actually look for existing legislation. I do also just want to point out that there's the I'm sorry, not California. There's the National Conference of State Legislatures. And so they have really cool resources there, like 50 state surveys and other policy briefs around different topics. And I'm sure there's a number that are related to oral health and dentistry, as well as public health. Okay, so let's talk about government agencies. And if you have any questions, by the way, as we go, just feel free to unmute yourself and ask questions. I'm happy to answer them as we go. So policies can also be made through government agencies, and there's two main ways that government agencies can play a role in policies and health policy change specifically. So the first is through the development of regulations as part of the rulemaking process. And then the second one is through enforcement actions. So let's start by talking about the rulemaking process, because this is a really amazing opportunity for dentists and also for public health professionals to get involved in the advocacy process. So basically, government agencies usually have a statutory authority to develop regulations through what we call the rulemaking process. And an example of this, sticking with our disabilities example, would be the Americans with Disabilities Act. So basically, they say you can't discriminate against individuals with disabilities, but they really don't elaborate. The law doesn't elaborate on what specifically you need to do to ensure that you're accommodating. So then different government agencies will create rules or regulations to say like, okay, specifically in this context, this is what you need to do. So one example would be the number of handicap parking spots in a parking lot, for example. Another example would be the Department of Education might create rules around like what elementary schools need to do or colleges need to do in order to appropriately accommodate individuals with disabilities. So that's where you really get into the specific details. So there's definitely, when the rule is proposed, it's published, and then there's what we call an open comment period. And that's the opportunity where you can weigh in as a dentist or a public health professional or just a community member to say, this is what I think the rule should actually look like. Here's where you have it right. Here's where you have it wrong. And here on the slide, I have a snapshot of a public comment from the American Public Health Association, and I also have a link on the slide. So I'm sure that AAPD also does something similar, and so you can check out their public comments. So this specific one is about the public charge. Does anybody know what the public charge is or want to share what it is? Okay, so public charge is a ground of inadmissibility in terms of kind of citizenship or related to immigration. So grounds of inadmissibility are reasons that a person could be denied a green card, a visa, or admissions to the United States. And in deciding whether to grant some applicants a green card or visa, an immigrant officer might consider things like if they took advantage of certain governmental benefits, or if they might need to take advantage of government benefits in the future. And that would make them, quote, a public charge, and so potentially inadmissible for immigration purposes. So this is kind of problematic, especially when we think about some of those services that are really designed to be a safety net for people and to promote public health. So here you can see that in this public comment, the opening paragraph starts with who has signed on to the letter. And this really highlights both the need for collaboration and then also interprofessional collaboration. And here's a place where public health and dentistry can really kind of work together, not necessarily on this specific issue, but just in general, where there's that overlap with public health and oral health. So here there are 630 national, state, and local organizations and agencies that represent a variety of sectors and stakeholders. The comment then goes on to provide an overview of the position, followed by developing an argument for specific recommendations for the rule. And if you're interested, you can read the full comment, which I have posted here. And actually, I want to just copy a link if you want to read more about public charge and immigration.
I have a question actually kind of for the other students that are in this discussion section. Have you guys noticed any particular pressing issues related to immigrants with dentistry?
Great question, Regina. So just to repeat the question, have issues related to immigration, have you seen that at all in your practices or in your conversations around policy?
Yes, we have. I mean, the residents were exposed last year to deal with these, I will call them refugee camps, where the parents were separated from the children in the border, and they were put into some sort of detention camps in Southern California in Orange County, and we were asked to be part of a group of dentists and dental providers to screen these children. So we end up bringing the kids to UCLA for treatment and care, but it was a very difficult, complex experience to realize that these children were all alone, separated from their families, all the trauma they had received. So I think that was a very fascinating example also of complexity and difficulty to address for our residents' perspective, but it was something that it really hit home very clearly for us, very, very close.
Thank you, Dr. Ramos. Does anybody want to add anything?
Yes, so I think, yeah, at UCLA, we so far, those of us who are first years haven't had the opportunity to see directly patients that have gone through any immigration troubles, but I think that in itself is to some degree telling of the fact of who has access to dental care, because I think a lot of times folks that are undocumented and stuff don't really get a chance to seek dental care in the United States. I also know that back at NYU, when I was doing my dental school, we did have a survivors of torture clinic that was more so meant for folks that were refugees that basically had gone through extraneous circumstances that had come to the United States and were waiting for refugee status. And this clinic kind of catered towards them. So I think, yeah, there is a lot that needs to be done when it comes to dentistry, especially for folks that are undocumented or refugees. And I think, yeah, we're very limited in sort of resources for them.
Thank you. Any other thoughts? So one other thing, Regina, that just kind of like jumps out is that there's been some collaborations with dental care and FQHCs. And so my guess is that there's a number of undocumented individuals or people experiencing issues related to immigration who go to FQHCs or federally qualified health centers to receive care. And so that might be kind of an avenue for kind of helping to increase access.
I'm sorry, I might add also in the good news is that we have a collaborative agreement with several of the migrant Head Start programs for this year to actually help out to bring some education and oral health awareness for migrant Head Start families. So the residents will be able to engage, and we look forward for Regina and others and some of your students to join forces and perhaps help us to spread the word with the staff, the migrant Head Start program staff and their families as well. We're going to have evening nights of oral health awareness for both in English and in Spanish. So we look forward for some collaborative efforts in the future.
Awesome, thank you. Keep me posted. Okay, so just looking at the time, I just want to make sure we can at least get through the government agencies, and then we can kind of pick up next time with the rest of the presentation. So in addition to public comments, there's also enforcement actions. So think about like your state public health department, who's going to be doing restaurant inspections as a way to enforce like food safety laws, for example. So every agency has a different way that they might enforce laws and a different complaint process. And here I just have a screenshot from the US Department of Health and Human Services. If a patient feels like their privacy rights have been violated under HIPAA, they can file a complaint. Now, some things are really clear cut, and it's really obvious that a patient's privacy rights have been violated, but not everything is, and there's a lot of gray area. And so really the complaints and the results from the complaints can kind of highlight kind of what the general practice should be, and can help determine what a breach is under the law for the future. So I just want to give a quick lighthearted example. I'm sure it wasn't for the people who bought the apps, but has anybody heard of the FTC, or the Federal Trade Commission? Okay, so what does the FTC do? What's their role? Okay, so the FTC works to protect consumers against fraudulent, deceptive, and unfair business practices. So here we have a case where there were two apps. One of them was called the Acne app, and the apps actually claimed that if a user held up a light generated from the smartphone, it would cure the user's acne. And surprisingly, around 15,000 people bought this app and another app. I'm sure they're all like middle school students who are really kind of having an issue. But anyways, so a complaint was ultimately filed with the FTC, who investigated, and a settlement agreement was put in place. Among other things, the apps weren't allowed to be offered on the marketplace. So I bring this up because enforcement actions like this really help to establish precedent and a course of action for health policy. So in the case of the Acne app, it helps set the precedent for unfounded medical claims on health apps, and provides consumers with recourse for these types of false claims and misrepresentation. Any questions about that? Or about like government agencies in general? I know it's like almost 5 o'clock on Friday. I'm sure everyone's ready to go. All right, so again, oh, go ahead, Wes.
I was just going to say, no, I'm very familiar with these processes. I work for Health and Human Services, and it is a long and arduous process that has a lot of steps to go through, and can be difficult for individuals to go through the process.
Yeah, absolutely. It can be a really bulky process. And that is definitely true. Okay, so it's 5 o'clock. This is the slide. Just want to bring your, for resources for government agencies, just want to bring your attention to the Federal Register, which is where kind of calls for open comments would be for at the federal level. So coming up next for next week, we're going to talk about executive orders, the judicial branch, and ballot initiatives, and we're going to talk about private organizations too, and some advocacy strategies. I'll stick around if anybody has any questions or thoughts, and otherwise I look forward to seeing you next week.